mute my toddler.
Thank you. I will start sharing. I'm pleased with this opportunity with the Bridge team, just to have the first journal club kicked on this hub. Is really useful hub and is really excellent opportunity for all of us at the trainee in Yorkshire, just to bridge this gap and have this a trainee-led hub. Thank you for Drs Morgan, whom I haven't met personally, and I'm really pleased to see you today and have this journal club with you. I'm going to share my slides, and just let me know if you can see it.
We've still got your presenter view, so we can see PowerPoint, we can see one slide, and then we can see the little slides down the left-hand side.
Is this still what you can see now?
Yeah. Teams is a bit of a pain. So if you stop sharing, Ella, I can help you here.
And I will just ignore the...
So if you click share content, and then at the bottom of share content is browse my computer.
Share content. It says, I don't have it.
And then if you scroll down, you'll get
browse my computer, yes.
Yeah, click on that, and then you'll get your option. You can just select your presentation there, and it will do a little think about uploading it. And then you should also be able to see all of us in the chat, and it's just a much nicer way of sharing in Teams.
Thank you.
That's all right. Took me about 2 years to learn it, so.
Coming.
Yeah, now we've got it perfect, and you should be able to click the buttons on Teams and it will move you through.
Yes. Can you
Brilliant.
see it moving?
Yes, we can. Perfect.
Thank you so much. So this is one learning at the first minute. So the journal club, or the paper I shared today, or I decided just to share with you guys, is about exclusive breastfeeding and risk of childhood cancer. It was a bit challenging for me to choose a paper that catch the interest of general pediatricians and oncologists at the same time, which is my area of interest. And I found this a useful paper just to share from like a whole health perspective. So we're going to have a introduction and speak about the backgrounds of breastfeeding, and then we go through a presentation of the article, and then we do the critical appraisal of the article. We share some clinical implications and future directions, and then the platform will be open for discussions and questions and answers. So as we all know, that breastfeeding is, as it says, is a natural safety net against the worst effect of poverty. And this word, or this phrase, was said by James Grant, who was the executive director of the UNICEF from 1980 to 1995. So breastfeeding, there are lots of researches and lots of studies and lots of work done with the breastfeeding and the aim of the exclusive breastfeeding. We all know that breastfeeding protects children from various illnesses and reduce risks of infections, of asthma, of heart disease, and also of sudden infant death syndromes. Breastfeeding reduces the likelihood of the childhood obesity and type 1 diabetes risks. And also there are some researches that says it increases the IQ. There is a increasing global breastfeeding rates. If there is increasing global breastfeeding rates, it could prevent thousands of childhood deaths and thousands of maternal breast cancer deaths annually. It supports mother and baby relationship and mental health of both baby and mother. It also protects children from mothers from breast and ovarian cancers, and also from heart disease. So this is all well-known effects and well-researched effects of breastfeeding And this is all comes from the content of the nutritional and immunological content of breastfeeding, which is like, we know it had lots of hormones, different types of hormones, anti-inflammatory factors, digestive enzymes, polyunsaturated fatty acids, growth modules, proteins. All of them work as anti-inflammatory effects, which when we talk about reducing the risk of infections, and also about the gut microbiome and the risk of, and they work as appetite regulator. So it helps with the weight management, it helps with the diabetes, and it helps with the growth, it helps with the brain development. But the paper we are going to discuss talks about, could breastfeeding potentially protect against childhood acute lymphoblastic leukemia? And this could be also through similar mechanisms that influence on the infant gut microbiome and the immune system, which are crucial in the BCL precursor development due to immune response and immune implications on infections. So this is an area of breastfeeding that this paper has studied. So this is the paper. So this paper was published in 4th of March 2024 on the JAMA Network Open, and you can just find it on the open papers. It talks about exclusive breastfeeding duration and risk of childhood cancer. It's from the study was done in Denmark. We'll go through all the details of this abstract of this paper and the discussions in the next slides. So the primary objective is to investigate whether longer duration of exclusive breastfeeding is associated with decreased risk of childhood ALL and sorry guys.
Gosh, you okay, Ala? Have you got a drink?
Sorry.
That's all right. Have you got a drink? Just take your time.
I'm recovering from a lower respiratory tract infection, so.
Oh, bless you.
And it's my first day back to work, sorry.
Oh, that's all right. Bless you.
So the secondary objective was to assess the risk of hematological cancers, CNS tumors, solid tumors, and other unspecified malignant neoplasms. And that's all in relation to breastfeeding duration. So this time we are talking about the breastfeeding duration, and it's not only the nutrients of the breast milk. And one of the secondary objectives was to provide more evidence on the relationship between breastfeeding and childhood cancer risk, and examine the effect of other co-founders like birth cohort, age at diagnosis, birth mood on the association between the breastfeeding duration and the cancer risk. So we're gonna, in the next slides, we will look at the population that has been studied and the interventions and the factors, the outcomes. So the population studied, as we said, it was children born in Denmark between January 2005 and December 2018. And the inclusion criteria, apart from this duration or children were born at this time, it was the availability of information on exclusive breastfeeding duration from the Danish National Child Health Register, and a follow-up was done until either from the age of 1 year until either childhood cancer diagnosis or loss of follow-up or migration, death, or until the age of 15 years, or the final was until the 31st of December 2020. So this was the inclusion criteria. Any child born at this time, any child has available information on exclusive breastfeeding, and children were followed up until from the age of 1 year. So the below 1 year were excluded. So until 1 year, until childhood diagnosis, either loss of follow-up or until the age of 15 or until the end of 2020. So the exclusion criteria definitely was the missing data on birth weight, gestational age, mother age, maternal educational level. Children with Down syndrome were excluded as well because they have high risk of leukemia. And also children born in Danish before there was mandatory reporting to the register, which began on 2012 on breastfeeding information, those were excluded. And of course, those who migrated and then diagnosed with cancer or died before the age of 1 year. I'm sure we can't see this very clear. It's just how it's shown in the paper. So is the baseline characteristics of the study population, which we have just discussed, and the duration of exclusive breastfeeding in infancy, according to the childhood cancer overall and to the ALL particularly. And in this flowchart, also they have described how the stages on how they have done the inclusion criteria to the study. So we just said it's in the previous slides, but this was like the stage how they have conducted. So first all the patients, and then excluding the missing information, then excluding the missing potential confounders, and then excluding the Down syndrome. So until we got to the final number. So what was the intervention done to this cohort of children? So they looked at the exclusive breastfeeding for 3 months or longer, and they compared it to exclusive breastfeeding for less than 3 months. So the design of this study was a prospective population-based cohort study, and it was approved by the Danish Cancer Society, and it didn't need any ethics approval or informed consent under the Danish law because it was just a cohort study register. It was followed by the STOP reporting guidelines, and the data source of this study was from the Danish Civil Registration System, the Medical Birth Register. They put identification numbers and got the information from the birth register, from the educational register, because they wanted maternal educational level. And they went to the national patient register because they were looking at, and the Danish Cancer Register because they wanted to look at the diagnosis of cancer on these children as well. So as we said, they created unique data, unique identification numbers. They looked at the birth characteristic, maternal educational levels, and the duration of exclusive breastfeeding on the data registered by the health care visitors on the health system. They identified from the Danish Cancer Register the cancer diagnosis and the age between 1 to 14 years, and they looked at the morphology and topography codes as well. So the definition of exclusive breastfeeding in this study is primary nutrition from lactation supplemented only by water and or at most 1 formula milk meal weekly. So this is a diagnosis of exclusive breastfeeding, which is different from the WHO definition of exclusive breastfeeding. And then they have calculated the duration until introduction of multiple formula feeds or solid food. The reporting compliance, so they went with the mandatory governance and a reporting, and they looked at there was the reporting of exclusive or the duration of breastfeeding, and the description of breastfeeding was mandated by the health system since 2012. 12. So earlier, the cohort which was studied before that missed some information about it because it was voluntary reporting and it wasn't mandatory. So all children who have missed information about breastfeeding on the cohort before 2012 were excluded. The statistical analysis, they used the Cox proportional hazard model and they adjusted for the co-founders, which we mentioned earlier, and they put sensitivity analysis as well. So in these two small slides, they looked at the hazard ratios of childhood cancer associated with exclusive breastfeeding duration, and they just put and adjust to the co-founders and adjust to the, looked at the age and the duration of breastfeeding. We'll look at it on details. They also, in this slide, you can see they looked at the hazard ratio of childhood B-cell precursor, acute lymphoblastic leukemia associated with exclusive breastfeeding duration of more than 3 months, and they compare it to the 0 to 2 months in this age cohort. So as we agreed earlier, the follow-up period was until childhood cancer diagnosis or until the loss of follow-up or migration, and until death or until the age of 15 years. And the analysis conducted using this version, the R version 422, it was a two-sided and with the P value less than 0.05 considered significant. They used the Cox proportional hazard regression. They stratified by sex and birth order. So they put like firstborn, secondborn, or 3 or more, age at the, and they put age as the underlying time scale. They have estimated also the hazard ratios and the 95% confidence intervals. The data analysis was conducted in this research between March to October 2023. The co-founders that they adjusted the analysis to were mother age at delivery, birth weight, gestational age, mood of birth, birth year, and mother educational level as well. So these were the adjustments or the co-founders that they adjusted the analysis to. They also looked at the cancer subtypes. As we mentioned, it was made the overall childhood cancer risk and specifically the leukemias. And in leukemias, it was the BCP-ALL. So they looked at hematological cancers, CNS tumors, solid tumors, ALL and BCP-ALL and neuroblastoma. They categorized the breastfeeding duration, approximately 3 months intervals. They put it either never or less than 14 days, 14 days to 2 months, 3 to 5 months, 6 months, or more. And then there was for the subgroups of the cancers, they put also additional grouping just to give it a bit of statistical power, which was 0 to 2 months versus 3 months. So as we said, there was supplementary analysis down here, supplementary analysis for the birth cohort. So between 2005 to 2011, where there was only voluntary documentation of breastfeeding duration, and versus the 2012 to 2018, where there was compulsory documentation on breastfeeding. They also put some supplementary analysis for B-cell precursors ALL incidence peak age, so 2 to 6 versus 7 to 14 years. And they also put supplementary analysis to the birth mood, vaginal versus cesarean section. So what was the outcomes or what were the results of this research or this paper? So there was total children of 309, over 309 studied in this paper. The follow-up duration was equivalent to more than 1 million person years, and the total cancer diagnosis in this cohort was 332 children, which is the 0.1% of the cohort, and the mean age at the diagnosis was around 4 years. Gender distribution, 58% were boys and 41 were girls. And in looking at the cancer types and subtypes, there were 37% of hematological malignancies, 65 of them were ALL, and of this, 90% were the BCL precursor ALL. There were 44 patients who had CNS cancers, 80 patients who had solid tumors, and there were about 84 patients who had others or unspecified malignant neoplasms. So in the breastfeeding duration, the categories, so exclusive breastfeeding less than 3 months, we had 33.6% children, or 104 children who had exclusive breastfeeding less than 3 months. And among those, 38% were diagnosed with cancer. And the adjusted ratio, the hematological cancer, so the adjusted hazard ratio was 0.66, so it was significant. And for the B-cell precursor, it was also 0.62, with no one there, so it was significant. But for the CNS tumors and for the solid tumors, the adjusted hazard ratio was 0.96 and 0.87. They looked also at the linear trend analysis, and for the hematological cancers, it was 0.9 adjusted hazard ratio per additional month, and it was of a similar figure for the B-cell precursor ALL. So they have detailed the outcome and the results based on the duration and based on the hazard ratio and subcategories of the childhood cancer. So the finding of this study was the longer duration of exclusive breastfeeding is associated with reduced risk of childhood hematological cancer in children, and particularly the ALL B-cell precursor. And this study supports the results from previous case control studies and is consistent with the emerging investigations implicating the early gut microbiome maturation and the pathogenesis of the gut microbiome on the childhood B-cell precursor ALL, which is the commonest type of the ALLs. And the implication of this study highlights the potential for protective effect of the breastfeeding against a B-cell precursor ALL, and it emphasized the need for further research, because this is observational research. So it emphasized the need for further research to understand the biological mechanisms behind this association, as we are only talking about duration now, but we are not talking about the biological effects on breast milk. The future directions following this paper could be just to continue investigate the underlying biological process and they develop preemptive interventions based on these findings. Okay, so we'll look at the critical appraisal of this paper. So as we said, did the study address clearly focused questions? What I can say is by defining the population and specifying the risk factors and aiming to detect a potential protective effect. So I can say that the study has maintained a clear and focused research question. And also, if we look at was the cohort reported in an acceptable way, or was the exposure accurately measured to minimize bias, was the outcome accurately measured to minimize bias? So if we look at these questions, what we can say is the cohort was recruited in an acceptable way. So the recruitment process adhered to the ethical standards, ensured representative sample, and tried to minimize bias. And also the study used objective measurement by relying on administrative data from a national health register, and included all children with available data on breastfeeding duration. So this could suggest that this had a comprehensive inclusion to the target population. So have the studies identified all important confounding factors, and have they taken into account the confounding factors in the design or in the analysis? So looking at this paper, you can see that while the study addressed several factors, as we spoke about with the birth cohort, with the birth weight, the mode of delivery, a maternal education level, and some other confounding factors. While the study addressed several factors, considering this, some additional elements like maternal health, lifestyle, environmental factors, family history, socioeconomic status could give this study more powerful consideration of results. And if we look also at the infections or the immune function of the child. So looking at the follow-up, while the follow-up of the subjects complete enough, and was the follow-up subjects long enough? So we can see that some children has been followed up for 14 years. So this provides long-term data. But there are some other children who were born at 2018, and the study closed by 2020. The follow-up closed by 2020. So some other children were followed only for 2 years, and this might not capture the late emerging effect, potentially introducing some bias and impacting the study overall reliability. So that's what I thought. So what are the results of this study? This is just like a recap or a repeat. So exclusive breastfeeding more than 3 months is associated with reduced risk of hematological cancers in children, particularly the B-cell precursor acute lymphoblastic leukemia. The cohort was more than 300, so it was a big cohort of children, and they were followed for a more than 1 million person year equivalent, which is a great follow-up time. The cancer diagnosis was subclassified into hematological central nervous system solid tumors and other unspecified malignant neoplasm. They have adjusted also hazard ratios for hematological cancers, which was 0.66 with 95% confidence interval with more than 3 months of exclusive breastfeeding. The adjusted hazard ratio for the B-cell precursor ALL was 0.62 with more than 3 months of exclusive breastfeeding. There was no significant association found for central nervous system tumors or solid tumors, as we seen earlier on the study. So how precise were the results? So they put the confidence intervals put for the hematological malignancies and the B-cell precursor ALL were statistically significant. So this is precise. We can say this is relatively precise, but there was a wide confidence interval for the other malignancies, so which suggests that there is no significant association. Do you believe this results? Okay, so it's a large population-based cohort study, so it minimized the selection bias. But as we said, it was initially a voluntary recall of the breastfeeding history, and it also depends on recall from mothers when you ask them and report it to the system. So this also gives a bit of potential, or it gives the potential for recall bias. So the confidence intervals excluded one, so it suggested they were not due to a chance, so they were statistically significant. They have done adjustments for co-founders, but as we said earlier, there was a room for some residual confounders possible, including family history, socioeconomic history, the overall health, including immunological and infectious disease health. Breastfeeding duration record before the cancer onset establish a temporal relationship, that's agreed. Longer breastfeeding is linked to a greater prospective effect on this study. Breastfeeding immune modulation and bioactive factors suggest there is a protective mechanism, but this is not the thing that's studied in this paper. The findings align with the same prior research, so just further studies are needed for more validation. Can the results be applied to local population? So what I thought, or if we think practically about the application. So this cohort study design is suitable for investigating the link between breastfeeding and childhood cancer. So in developed countries which have the similar healthcare setting, the findings are more directly relevant because there are similar healthcare and socioeconomic factors, although there might be some cultural difference or some policy variations. When we look at underdeveloped nations, the difference in the health care access, nutrition, and infectious disease poses challenge. So we know that the breastfeeding has the most value on poverty, as we spoke earlier. But when they think about it from the nutritional point, and they think about it from the infection prevention point more. I say it poses challenge, but I think it also at the same time could carry more encouragement, because it's not only the infection and it's not only the nutrition, it can also protect from cancers, development of childhood cancer, which can also make a lot of cost to that weak healthcare system. So it can work in both developed and undeveloped countries. So global promotion of breastfeeding warrants adaptation to local context through tailored support systems and policies, and it should be supported by localized research. Okay. The results of this study, are they related to previous evidence? Yes, there were some meta-analyses and pooled studies that have shown children breastfed for at least 6 months had approximately 20% lower risk of developing ALL or leukemia in general compared to those with breastfeeding of shorter duration or not at all. What are the implications of this study in practice? As we stated earlier, it's an observational study. So we say that observational studies are limited compared to randomized controlled trials due to the potential bias and the confounding factors. But at the same time, because we are studying breastfeeding, so one observational study could provide, it rarely provides sufficient evidence recommended to be widespread or to make widespread change in clinical practice. But a question related to long-term health outcomes and rare conditions, observational studies may provide a feasible evidence. This study also, because it's a large cohort and extensive follow-up offered for 14 years, it provides valuable insights which are really challenging to be obtained through randomized controlled trials. So what is the strength of this study? It's a large cohort. It also had a longitudinal design, which allows tracking of the participants over time, providing insights into long-term effects. It had comprehensive follow-up, extensive follow-up periods, which enable to give a detailed assessment of outcomes. It also had real-world relevance, so it had observational nature. It reflects real life conditions and behaviors. It studied multiple various confounding factors, and it also consistent with previous literature and aligned with existing research on breastfeeding and childhood cancer, and is also applicable to provide insights insights to similar populations and healthcare settings. What are the limitations of this study? So there is potential for bias, as we said, with some confounding variables influencing the results. The reliance on self-reporting data and possible misclassification of exclusive breastfeeding duration could introduce inaccuracies or recall bias. So if you don't specify exclusive breastfeeding, especially for the cohort before 2012, if there is no clear specification or identification of what we mean by exclusive breastfeeding, a mother can think that she is giving exclusive breastfeeding if she gives just 1 or 2 bottles or 2 to 3 bottles a week, which is not the definition we are using here. The observational nature limits establishing causality between breastfeeding and childhood cancer, and also, as we said, variation between the study definition of exclusive breastfeeding and WHO guidance may impact the comparability and implementation of these results or these outcomes outside or in different healthcare settings. Recommendations. We will say the same. The recommendations will be stronger when they are supported with similar findings from other research, including meta-analysis and systemic reviews. But healthcare providers and public health officials, they should continue to promote exclusive breastfeeding support due to the potential reducing childhood risk, and the policymakers also should consider looking at this study and establishing broader evidence-based support of breastfeeding promotion. This study also could be used to help with the public health campaigns to inform parents about the long-term benefits of breastfeeding, and there is a need for further research to confirm these findings and inform more of evidence-based recommendations. Thank you. Is there room for the discussion?
Thanks, Ella. Really well done presentation. Lots of applause happening. Everybody trying to find the react button. And it's also nice to see people you won't have seen Ella, but in the chat, people have been introducing themselves, saying who they are and where they work. And we've got a really nice range from ST1s to ST7s. And everybody in between, and from the look of things, some good geographical cover as well, so that's always really nice. Farine, shall I hand back to you? I saw you appear. Oh.
Yeah, so thank you, Anna. That was really, really well presented and really well described. So thank you very much. Does anybody have any questions? I've got a slight question, but does anybody else have any questions? You can either pop them into the chat or you can speak out. So I'll let people have a think first. But just as quite a basic question, they excluded anyone with cancers before the age of 1. This might be really obvious to people, but it's not obvious to me. Why was that? Does that make sense to you? And is that because the duration of breastfeeding wasn't over yet?
Oh, hello, you're on mute.
Yes, sorry. So they spoke about this age because it is quite a different the cancer development also when they studied it is a bit different from when it comes after 1. So and they when you look at the studies of the development of cancer within the first year, is different on the pathogenesis in somehow. And as you spoke about the duration of breastfeeding, and we are looking at long-term effect. So the duration of breastfeeding is going to be less than the long-term effect that we are looking at. I don't know if Jess has a better explanation.
No, I agree. So I think there's kind of 2 rationales. The research rationale, which is your exposure and your event happening temporarily quite in a mixed up way, and then it becomes more difficult to pick apart. But actually, medically, infant ALL is a very different disease compared to childhood ALL, with different mutations, different prognosis and different treatment. So the under ones, certainly in haematological cancers, managed very differently from the over ones. So probably in terms of purity, and I think going into this study, they clearly were thinking it was ALL they were going to find out about. That's where all the suspicion lies, and everybody else got included because, you know, if you're doing the work, you might as well look at the CNS and the solids and just confirm that the impact isn't there. But also looking, and you guys don't have this joy, I'm looking at the names and knowing the people is they are hematological people. So, you know, there's kind of a heads up that that was what they were looking for. But it makes sense to me in both forms of my brain. Somebody's got their hand up.
Yes, so Victoria, you would like to ask? Unmute and ask.
Hi there. So I'm an ST1. So I guess my question would be: is how would you explain this information to a parent? Because obviously I think it's quite important information to them to understand. But how would I translate this from science into English? Does that make sense?
Brilliant. And that is always the question. And I was mulling on that all the way through your presentation, actually, Ella, because I was thinking about it as a hematologist. Well, not a hematologist, I'm an oncologist. Thinking about it as somebody who looks after children with cancer versus if you're the person giving the breastfeeding advice much earlier on. And I think you would take a different approach. Hello, this is appropriate paediatric journal clubbing. To have a small person join the audience. So Ala, maybe you could have a think about how you would communicate this.
So I think if I would just check their background knowledge, what they know about breastfeeding, and what then I can build up. So if they will tell you what they know about it from the nutritional point, then you can tell them that you are going to add a more positive impact of it, which is this, and this is all coming from the components of the milk that goes into the gut, which breast milk is the natural milk that children receive unless there is necessary for, or there are some other contexts. So you will tell them that is in addition to the effects, to the good effects on the weight with the gain, on the prevention of the infection, and this, it also helps in the development of healthy gut, which has a major effect on reducing the risk of some types of cancers, and especially the leukemias. I know many of the audience has better ways to say it, but this is what I thought about it.
Yeah, no, I think that's it. You know, this is information you have to share. It probably is, you know, from what we're seeing, a pretty robust study that says that breastfeeding is likely to reduce your risk of ALL. I think, as you've said all the way through, Ella, that the other benefits of breastfeeding are more significant and should be stressed. And I think this is almost a downplay in the sense of we know it wouldn't prevent every form of ALL, it wouldn't prevent every case. And we know there are lots of pressures on mothers to breastfeed already. So it's about sharing information without placing responsibility, is that the right word? Or blame if you're unable to breastfeed. I think those are really difficult conversations to have. And I also think that for myself, you know, once you are faced with a family who have a childhood cancer diagnosis, actually talking about risk factors obviously often isn't helpful, and certainly the discussions about why this happened to their child, you can almost never define why a cancer happened to their child at that moment. And it's often of more benefit to be able to say, we don't know why this has happened. We know risk factors, but we don't know, and we'll never place blame on a family. You know, if somebody came and said, I bottle fed my 4-year-old who's now got ALL, I certainly wouldn't be saying that's the reason they've now got ALL. So it's a very tricky discussion, isn't it? What were you thinking? Is it Victoria or Vicky? Sometimes Teams gives you a full name when you don't prefer it.
Victoria, it's usually because I'm currently in Scarborough and we get a big mix of patients. So we get everybody from the little sort of newborns, all the and the ex-preemies, all the way up to we get quite a lot of cancer patients because they come here on holiday. So it's kind of like sometimes we get thrown these questions and you know, just like do you know what I mean? Like it's not just because we're a bit more local that they feel like they can ask us those. I don't know. I think I quite like numbers, so a big one I like. No, because like the one I like for smoking is like I understand smoking is really difficult to give up, but we know that if you smoke, your child is 7 times more likely to smoke. I just like a number, so it's not like it's like a blame thing. I feel like numbers sometimes help like diffuse a situation a bit, but yeah, that was just the reason why.
Brilliant. Well, Anna, I wonder if you could share the slide that had the hazard ratio answers on it, because I think I know for myself that this was one of the hardest concepts to understand, and might be something that everyone's kind of gone, well, statistics. Sorry, that's me being reminded to go to clinic, so I'll do this chatting and then I'll disappear. But hazard ratio, so perfect, that's the one we want. So I wonder if we're all finding that left-hand box about what percentage of people were breastfeeding. That's probably quite easy to understand. What about hazard ratios? Would anyone like to have a stab at interpreting something in the right-hand box? You can pick which one you like, but have a go at saying what that means in real people's language. You can type it in the chat or you can try and say it in words. Silent. Shall I have my stab at this? And I will, for those of you who don't know me, I will say I mostly do qualitative research. I do systematic reviews as well, but usually not of the form that require difficult statistics, and usually of the narrative synthesis approach. So my stats are not as good as some of my incredible colleagues, but I can give it an interpretive go. So hazard ratios, so you all know ratios are about comparing X to Y, and in this case we're comparing what is the rate of hematological cancers in people who breastfeed for more than 3 months versus those who don't exclusively breastfeed for more than 3 months. And it's saying that if you exclusively breastfeed for more than 3 months, the risk or the hazard of having a hematological cancer is 0.66, so 2/3 as many. But this is quite a wide confidence interval, so it's saying any of that number could actually realistically lie anywhere between 0.45, 0.46 and 0.95. So it might be a small reduction, but actually it feels like it's probably quite a moderate reduction in the risk of hematological cancer. And that is sort of the same-ish in B-cell precursor ALL, so sort of common ALL for those of us who work in this world. And then the risk in brain tumours and solid tumours it looks like it's slightly less, but it's not statistically significant. And it could be that the risk is actually greater if you breastfeed or less. But again, very wide confidence intervals. And this is showing a really the impact of low events. So when you have something as rare as childhood cancer, you need absolutely massive numbers to find statistical significance, because these were big numbers, and it's only just showing statistical significance in leukemia, and it can't really tell us in the other groups. In terms of the log linear trend analysis, this is just saying that for every additional month that you breastfeed, you're reducing the risk by about 0.09, so about 9%. So again, making that for families to understand, for people who you're talking in the general public, I would, again, I don't always use numbers, I use more small to moderate, or reducing by about 1 in 3, but everybody's different, and different people like statistics compared to not liking statistics, and you've sometimes just got to go with the patient and the family in front of you in terms of their understanding of these kind of numbers. Did that make sense? You can do thumbs up or thumbs down.
Yes, that was a lovely explanation, Jess. Thank you.
By a non-maths person, did you see it, Marina?
Well, it was not statistically said. It was nicely said in plain language, so which is what is important for parents.
You agreed to? Yeah, it's really hard statistics. That's how I feel a lot of the time. Good. Well, Ala, do you want to wrap up, given that Verina's got her hands full? And I will say it was really nice to meet everybody. I'll put my email address in the chat. A bit of a plug. So I'm a part-time peds oncology consultant, mostly treating solid extracranial tumours. But I also work as a researcher at the University of York, and I'm Deputy Director of the Candleitis Supportive Care Research Centre. So if you are interested in supportive care research for children with cancer, then we are the people to reach. But similarly, if you're interested in research and you just need some contacts, I'm always happy to try and find you somebody who knows more. So I'll put my NHS email into the chat. I'm not always on top of my NHS email account, but that's okay. Just keep going and I will eventually reply to you. Ala, handing it over to you for finishing.
Thank you so much. Thank you so much, everyone. It is an excellent opportunity, learning opportunity for all of us on this journal club and research activities and understanding of the statistical relevance and application to real life scenarios. So just I was thinking about if there is any feedback link by the Bridge team, because this is what I came to know.
Yes, so thank you very much for joining us today for this journal club meeting, and thank you very much, Ala, for such a fantastic presentation of a paper. I thought it was really good and a really good start to our journal club journey. So next meeting that we've got is in August, on the 20th of August, where Aoife Hurley, a neonatal SDH trainee, is telling us about how all QIs are opportunities for posters and publications. So it would be lovely if those that joined today could join next time for some more fun on making the most of our academic journey. And then here is the link for the feedback form for today. And can also pop it in the chat for you. But here is a QR code so you can get your cameras out and get that feedback form up. So thank you very much. I'll leave that up, and we can also pop that link into the chat, or I will do my best to.
Thank you so much. It was an excellent opportunity. I will really appreciate your honest feedback. Is an area which I didn't have experience on before, so I really appreciate that. Thank you so much, and I hope we'll all lead this research hub and for more of a development and expert. Thank you so much. Thank you. Okay. Diane and Verena,
Hi,
how are you
thank
doing?
you. I'm here. I'm just
Hello.
unmute. That was so
Thanks
amazing.
to Anna.
Thank you so much, Ella. I was
It
just
wa-
feeling all these.
You
Yeah.
wouldn't believe this is my first experience with Journal Club. So
Gosh,
it was
you did
so
well.
stressful.
It was
No,
really good.
It
Thank
was
you.
really, really good. Really,
Yeah.
really well prepared. Really lovely slides. It was, yeah, it was terrific. Sorry about this.
No, we love to see
Invader to
them.
the
We love to see
who
them.
has decided to not sleep right now when she was supposed to.
Bless her.
Right.
Thank you.
Thank
Okay,
you. We'll
thank
send the
you.
feedback to you, Ella.
Mhm.
Yeah, we'll send the feedback to you once we
All
have
right.
it together. Yeah.
All
Thank
right,
you
that's
so
great.
much.
Thank you so much.
Okay.
you.
All right.
All
Bye
right,
now.
thank you.
Bye.
Bye. Bye.
Bye.